Let's explore the accuracy paradox in medical AI and why understanding it is essential for safe clinical deployment. Imagine an AI diagnostic system boasting 99% accuracy that somehow manages to miss every single case of disease. This counterintuitive scenario is precisely what we call the accuracy paradox, and it represents one of the most critical challenges in medical AI evaluation. To understand this paradox, we need to distinguish between two fundamentally different types of classifiers: trivial classifiers that game the metrics versus useful classifiers that actually learn meaningful patterns. A trivial classifier simply predicts whatever class appears most often in the data. In medical datasets where healthy patients vastly outnumber sick ones, this strategy achieves deceptively high accuracy while being completely clinically useless because it misses every positive case. In contrast, a useful classifier actually learns the distinguishing patterns of disease. And even though it may report a lower final accuracy number, it successfully identifies the majority of true disease cases, which is what actually matters in clinical practice. So here's the critical question. Would you rather have a system with 99% accuracy that classifies every patient as healthy, or one with 95.8% accuracy that correctly identifies most of the people who actually have disease? This problem arises because medical data is inherently imbalanced. When we collect health information from large populations, most people are healthy and only a small fraction have any particular condition, making raw accuracy a dangerously misleading metric. When AI systems fail to detect disease due to poor sensitivity, the consequences cascade through a patient's healthcare journey in devastating ways. In the early stage, the AI's low sensitivity causes an initial missed diagnosis, meaning the patient is falsely reassured that nothing is wrong. As time passes, the undetected disease continues to advance and progress beyond the stages where treatment would have been most effective. By the time symptoms become impossible to ignore, critical intervention windows have closed, and timing-sensitive treatments can no longer be offered. Ultimately, the patient suffers negative health outcomes, potentially including permanent disability or even death, all stemming from the false reassurance provided by an AI system that appeared highly accurate but couldn't actually detect disease. This progression from misdiagnosis to patient harm illustrates why other metrics, not raw accuracy, must be prioritized when evaluating medical AI systems. Not all diagnostic errors are created equal. A false negative means a sick patient is told they're healthy, leading to delayed treatment and disease progression. While a false positive means a healthy patient undergoes additional testing but ultimately receives correct information, the consequences are dramatically asymmetric. Given that accuracy fails us in usually imbalanced medical data, let's examine the alternative metrics that actually capture what matters clinically. Sensitivity, also called recall, tells us what proportion of actual disease cases the system correctly identifies. This directly answers the question, if I have the disease, will the AI find it? Specificity measures the proportion of healthy patients correctly identified as healthy, answering the complementary question of how many false alarms the system generates. The F1 score combines precision and recall using a harmonic mean that penalizes extreme imbalances, ensuring a classifier can't score well by excelling at only one dimension. The Matthews correlation coefficient incorporates all four cells of the confusion matrix and treats both classes symmetrically. Balanced accuracy averages sensitivity and specificity, giving equal weight to both classes regardless of how imbalanced the dataset is. Let me summarize the key principles that should guide your evaluation of any medical AI system. First and foremost, never trust raw accuracy alone. It can be completely misleading about clinical utility. Always ask whether the system can actually detect disease when it's present, because that's the fundamental purpose of a diagnostic tool. Demand transparency from AI developers and vendors. Request confusion matrices and learning curves, rather than accepting final accuracy numbers that may hide critical weaknesses. Finally, recognize that medical AI evaluation must explicitly weigh errors according to their clinical consequences. Missing a cancer is not equivalent to an unnecessary follow-up test. To explore these evaluation frameworks in greater depth, my books on this subject equip clinicians, researchers, and healthcare administrators with the tools necessary to evaluate AI systems before clinical implementation. I'd like to close with specific calls to action for everyone involved in the medical AI ecosystem. For clinicians, question any AI system claiming high accuracy without also demonstrating robust sensitivity data and evidence of healthy learning dynamics. Don't be impressed by accuracy numbers alone. For developers, design your evaluation protocols to genuinely reflect clinical priorities and patient safety, and collaborate closely with medical professionals who understand the real-world consequences of diagnostic errors. For patients, become advocates for clear and transparent AI performance reporting in healthcare. You have the right to understand how these systems are being evaluated before they're used in your care. Thank you for your attention. I'm Dr. Toma, Associate Professor at the College of Osteopathic Medicine, New York Institute of Technology, and I'm happy to discuss any of these concepts further.